Because of the online character of the course today, we were not able to provide with a live scan, so we decided to do a presentation about the sonographic recognition of normal fetal brain structures instead of the live scan. The fetal brain is, I think, one of the most interesting parts of the fetus, but also one of the most challenging parts because its appearance changes during pregnancy and during development, which makes it a lot more difficult to assess. In the assessment of the fetal brain, the guidelines of the EASWOG can help us. We have two parts, one basic guideline and one advanced guideline. And if we look at the basic guideline, what we assess there is our transventricular plane, and where we can see the midline, the bullocks. We can see the cavum septi pellucidi over here, which is rectangular, and on 1/3 of this midline we can see the anterior horns, which are in a V-shaped position on this midline. We can see the lateral ventricles over here with choroid plexus, and you can see here the beginning of the sylvian fissure. If we tilt the probe a little bit, we get the transcerebellar plane, where we can of course see the cerebellum. We can see the cisterna magna over here, and if we measure this should not exceed 10 millimeters. We can see both thalami over here. Also, you can see that the cavum septum here has a little bit different shape and more of a triangle, and again the frontal horns over here. If we move back a little bit, we have the transthalamic plane, where we can see both thalami over here with the third ventricle in between. This is a slit-like structure with a little bit of fluid inside. If we look at the lateral ventricle, we measure the lateral ventricle in the posterior horn from the inside of the ventricle wall to the opposite inside of the ventricular wall over the glomus of the choroid plexus. And this should not exceed 10 millimeters. If there is ventriculomegaly, it's really important that you can measure during gestational age if this ventriculomegaly increases. And then it becomes really important that you always measure the ventricle on the same side, on the same spot, and to really can see if there's an increase. So what Guibault proposed is that you measure the lateral ventricle opposite to the deepest part of the parieto-occipital sulcus. So this will give you a point where you can always measure the ventricle at the same spot. So far the basic scanning. Then if we go to the advanced fetal neurosonography, first of all the performance, and normally we scan transabdominally, but if the baby is in a vertex presentation, you also could scan transvaginally. There is a lot of reluctance to do a transvaginal scan, but our experience is that the reluctance is mostly from the sonographers and not so much from the patients. If the baby is in a breech position, you could also try to put the mother in an upright sitting position and let her bend a little bit forward, and then through the fundus you can scan the head of the baby parallel at the abdomen, and it will give you nice images. Of course, it's also possible to do an external version and scan transvaginally. And a little bit more about transvaginal scanning. This is quite recent case where we had a twin pregnancy where we had to perform an advanced scan, and the first baby was a little bit engaged in the pelvis of the mother, and this was all we could see transabdominally. But when we went to do a transvaginal scan, we get these really great images. So I think there's really an advantage in transvaginal scanning. We're very used to look in axial planes, but I think it's also important to look in coronal planes and in sagittal planes. If we look at the coronal planes and we take the first plane, then you can see here the intrahemispheric fissure above both eye sockets. If we go a little bit more posterior, you can see here again the cavum septi pellucidi, the frontal horns in this feel-like shaped structure, and there you have your corpus callosum. If you look a little bit more posterior, you have both, we get the transthalamic plane and we can see both thalami over here with the third ventricle in between. And then completely in the back of the head we can see the transcerebellar plane, where we can see the cerebellum over here, and there we have our tentorium, and there we can see both lateral ventricles, which is an advantage because sometimes in the axial plane you can only get a good look at the half of the brain which is the most far from the transducer, because the part that is most, which is close to the transducer, always has a lot of shadow because of the fetal skull. And so in this plane you can see if there's symmetry of both lateral ventricles. Then we look at the mid-sagittal plane, and you can get this plane by scanning through the anterior fontanelle, and then you get the mid-sagittal plane and the parasagittal plane. In the mid-sagittal plane you can see the cavum septi pellucidi with the corpus callosum over here. Here you can see the third ventricle, which is which has a little bit of fluid inside. And if you get a parasagittal plane, then you can see the brain parenchyma really nice. And this is useful if there are problems like a hemorrhage, or if there is ischemia, or if there is an infection, when you want to look at the brain parenchyma. If you scan through the posterior fontanelle, you get this mid-sagittal plane, and where you can see the vermis, where you can see the fourth ventricle over here, where you can see the tentorium, and here you can see the cisterna magna. So these are the planes that can help us assessing the fetal brain. But we also want to take a look at the cortical development. And for this we need to look at the cortical sulci and gyri, of which there are many, with a lot of different and complicated names. There are a few which we can assess at ultrasound. For instance, the sylvian fissure. That's this fissure over here. It's one of the first fissures to appear during development. And then we have the second sulcus, which is the superior temporal sulcus, which you can see over here in the temporal lobe. We have the central sulcus over here between the frontal lobe and the parietal lobe. And there we have the parieto-occipital sulcus over here between the occipital lobe, the temporal lobe over here, and here the parietal lobe. If we look mid-sagittally, we see, of course, again here the corpus callosum, and with the cavum septi pellucidi over here, and here the fornices. And over the corpus callosum, we have the callosal sulcus, and a little bit above this one, we have the cingulate sulcus. And here, between the parietal lobe and the occipital lobe, we have again the parieto-occipital sulcus. And here, on the inside of the occipital lobe, we can see the calcarine sulcus. So these are a few of the sulci that you need to remember, so you can look at them on ultrasound. So how are you going to do that? Well, if we take this plane we get this ultrasound image. And if we look here, then we can see the sulcus, which is the Sylvian sulcus of the Sylvian fissure. There, over there, we have the superior temporal sulcus. If we have this plane a little bit higher inside the fetal head, we can see this sulcus, which is the central sulcus over here. And then we have this sulcus over here, which is the parieto-occipital sulcus. If we take this coronal view, we get this image, and then we have here our corpus callosum, and there we have a little bit above our corpus callosum, we have our cingulate sulcus. And then there, of course, the lower one is the callosal sulcus. If we go a little bit more to the posterior part of the brain, we can see here the cerebellum. Then we have here our parieto-occipital sulcus over here, and there we have our calcarine sulcus over here. If we make a parasagittal plane, we get this image, and there we can see the central sulcus over here. So now we know a little bit more of which sulci we can assess on ultrasound, but then the next thing is that these sulci are developing over time during development. And this is a nice overview of what, how this development looks like. Here we have, these are MRI, fetal MRI pictures, here where you can see here the axial views. Here we have the coronal images, and here we have the parasagittal images. And here you can see that at 22 weeks we have the Sylvian fissure over here, which is a small indentation. And if we look throughout development, we can see that this sulcation becomes deeper. And you can see that the brain parenchyma of the parietal lobe and the frontal lobe are increasing in size and growing over this Sylvian fissure or insula, which is called operculation. If we look at the coronal view, you can see again here this Sylvian fissure becoming deeper and deeper, and you can see that the brain tissue is growing over this insula, almost closing it down. Here at the parasagittal view, you can see that there the central sulcus occurs, and at 22 weeks you can't see it, but at 25 weeks it started to show itself. It becomes deeper and deeper, and of course also on the surface of the brain you can see the gyrian sulci appear. On ultrasound, you can see here at 20 weeks a little bit of the parieto-occipital sulcus, and you can see here the beginning of the insula of the Sylvian fissure. Here at 26 weeks you can see that the insula is deeper, but you also can see that here the temporal superior sulcus is appearing, and here you can see even more of the insula or Sylvian fissure, which is almost completely operculized. You can see more and more sulci appearing at the surface of the brain. Another thing, what is really important is that asymmetry is normal, and this is a really nice study of Gregor Kasprian, where you see these coronal images of fetal brains, And if you take a close look, you can see here that at 26 weeks, the temporal superior sulcus is appearing. But on this side it is, and on this side it isn't. And during development, you can see that on one side it appears earlier and it is more advanced in development than on the other side. And this is completely normal. So asymmetry is normal. Then we're going to take a closer look at the corpus callosum. Here, the schematic view again. Here we have the corpus callosum. We have the cavum septi pellucidi. We have the fornices. And if we take a look at the axial view, again, the cavum septi pellucidi with the frontal horns over here. The cavum septi pellucidi is patent during fetal life, but then the cavum disappears and a septum pellucidum is what's left of it, with the corpus callosum here above it and the frontal horns over here. So below 18 weeks, it looks like this. Between 18 and 37 weeks, we have a normal cavum septi pellucidi, and after 37 weeks, most of the cavum septum isn't visible anymore. So if we want to look at the corpus callosum, we have to make this mid-sagittal view. Because if we know that if there is a cavum septum, there should be a corpus callosum, but you're not sure if the corpus callosum is completely there. If you have a partial agenesis, mostly the last part of the corpus callosum is missing. So if you want to see if there is no partial agenesis, you do have to make this mid-sagittal view, where you can see the corpus callosum over here with the cavum septum over there. If we look at this coronal view, we have the corpus callosum over here, we have the cavum septum over here, and if we make this plane, then you get this recognizable plane of the head circumference with the cavum septum over here. And if we look a little bit lower, we get this image where we can see both fornices over here. So sometimes you make a picture where you can see that when you think you see the cavum septi pellucidi with this extra line inside there, but then you know you're a little bit too low, you're in the plane of the fornices. And of course, if you make this plane, you will have the mid-sagittal plane with the corpus callosum over there and your cavum septum. This can be really challenging in 2D, so that's where 3D can help us making a volume and be able to render the mid-sagittal plane. Then we have the cavum vergae. What you can see then is a cavum septum which is a little bit extended backwards, so it's larger. And when you make a mid-sagittal plane, you can see your corpus callosum. You can see your corpus callosum over here. There your cavum, and this extension is your cavum vergae. And a cavum vergae is a variation of normal. What can happen is that someone is referred to you because there is a cyst-like structure in the midline. And then it's really important to make the mid-sagittal view, like you can see over here. Because if we look at this plane, the yellow one, we can see the enlarged cavum septi pellucidi. And when you go a little bit lower, you get this plane where you can see that you have your cavum septum, but in this one is your cavum vergae and not a cyst. And so therefore it again is really important to look at the mid-sagittal view. Another thing that we see more and more is the cavum veli interpositie. because our ultrasound machines are getting better and better, we can see more detail every time. En een cavum-feli interpositie is a variation of normal if it's isolated. And again, this is a midline structure, a midline cyst-like structure that you can see. And again, it's important to make your mid-sagittal view. You can see here your corpus callosum. You can see your cavum septi pellucidi, and here at the tail of your corpus callosum you can see this cyst-like structure, which is your cavum-feli interpositie. Of course, in your differential diagnosis you have to think about an arachnoid cyst or a veno-vagale malformation. It's important to make this mid-sagittal view. And here you can see a schematic drawing of the cavum septi pellucidi, your cavum vergae, and your cavum-feli interpositie, which are all spaces that are going to disappear during development. And with some babies they disappear a little bit later than usual. Here at a 3D image of a baby at 20 weeks, where again, here we have the cavum septum, and here we can see the cyst-like structure. But if you make your mid-sagittal view, you can see your cavum septum over there. And here your cavum-feli interpositie. You can measure the corpus callosum. How big is normal? Well, you can measure it in very different ways. You can measure from the outside to the outside, the inside. You can trace the corpus callosum. You can measure the thickness of the corpus callosum. And for all this, there are reference charges of what is normal and what is not. In eyeballing, the corpus callosum is almost 1/3 of the frontal to occipital diameter of the fetal head. And then we have another structure which can help us to look at the corpus callosum, which is the pericallosal artery. This is a branch of the anterior cerebri artery, and there are two of them. So there are also two pericallosal arteries, and they are running around the corpus callosum like this. So if you're having difficulty in looking at the corpus callosum, you could look with your Doppler to look at the pericallosal artery. And it's a bit like with the kidneys. If the renal artery is there, then you know there should be a kidney. This is the same. If the pericallosal artery is there, there should be a corpus callosum. So to conclude, a good knowledge of the normal anatomy and development of the fetal brain is necessary. Look at the brain in axial, sagittal and coronal planes. 3D sonography can be of help, and do consider vaginal imaging. Okay. Thank you for your attention.